And this will be shown by Dr. David Waller. He's a well-known European thoracic surgeon at Glenfield Hospital in Leicester in the UK. And the title of his presentation is that increased investment in thoracic surgical expertise increased the UK lung cancer resection rate.
Paul, thanks very much. So my name's David Waller. I'm a consultant thoracic surgeon, a pure thoracic surgeon. I work in the Glenfield Hospital in Leicester in the United Kingdom. I'd like to summarise the results of a presentation just made by my senior registrar Kelvin Lau at the presidential session. I want to describe to you the effects we found of investing in thoracic surgery on lung cancer resection rates. The background is that in the UK, lung cancer has been undertreated. There is evidence that in comparison to other Western and developed countries, our treatment rates and survival for lung cancer fall way below the accepted standards. This has been focused on by the British media, and hopefully some changes have been made as a result. Within our country of around 60 million people, there is a wide variation in the access to lung cancer surgery. As you can see from this map, there are areas of the country which have a six-fold greater resection rate. Just to put that into perspective, if you are an elderly patient with lung cancer in Cornwall, you are 6 times less likely to get lung cancer surgery than if you live in Leicester. And clearly this is of major concern both to the patients but also to the politicians. As you can see here, this again has attracted the attention of the British media in the past. This graph shows the resection rate adjusted for various confounding factors such as sex and age. This is a real difference. The background to this is the standard UK lung cancer pathway. Because of our state healthcare system, virtually all cases of lung cancer are referred in from primary care to a specialist lung cancer service. They are initially screened by a chest physician and then discussed at a multidisciplinary team, which will include a chest physician, an oncologist, and hopefully in most cases a surgeon. But this is the first point where the surgeon is involved in the lung cancer pathway. And unfortunately, it is the case in the United Kingdom that not all cases of lung cancer are discussed in the presence of a surgeon at the MDT. The decision is made by the MDT then to refer the case on to the surgeon. And as I'll show you, in the United Kingdom, if you have lung cancer, you may or may not see a surgeon who has a specialist interest in that disease. One of the benefits of this, one of the aspects of this presentation has shown the benefit of the National Lung Cancer Audit, which is a way of recording all the data pertaining to lung cancer patients within our state healthcare system. And our presentation is based on the analysis of its results. Within our national healthcare system, I'm focusing now on England, there are 33 cancer networks comprising 174 hospital trusts. 18% of these trusts have thoracic surgical centres. But in 58% of these trusts, there are less than 2 pure thoracic surgeons. In 2008, which is the last analysed lung cancer audit, over 15,000 confirmed cases of lung cancer were in the United Kingdom, and 14% underwent resection. Data from the Centre for Workforce Intelligence, current data in England, shows this distribution. Less than half of the surgeons operating on lung cancer are pure thoracic surgeons. There are 63 surgeons whose practice combines both cardiac surgery and lung surgery. And there are 114 surgeons whose surgery comprises entirely heart surgery. Our analysis in this presentation related the data from the National Lung Cancer Audit to manpower data obtained from that last source. And these are the main findings. Lung cancer resection rates are higher in centres who treat more cases. Lung cancer resection rates are higher in patients who are first seen in one of the specialist centres, the base centres where there is thoracic surgery, rather than in the referring centres. Importantly, lung cancer resection rates are higher in centres where there are 2 or more specialist thoracic surgeons as opposed to cardiothoracic surgeons. And, reflecting the lung cancer pathway, lung cancer resection rates are higher, significantly higher, when surgeons attend preoperative MDTs. And we found that after the analysis of the 2008 data, there were appointments in 5 of those 31 units of new specialist thoracic surgeons. When we reanalysed the changes in resection rates, surprise, surprise, the increase in resection rate was greatest in those units who had employed new specialist thoracic surgeons. What does this analysis mean? If we look at the implications for the lung cancer surgery workforce, and we take the network that had the best resection rate in that data, they had 3 pure thoracic surgeons who saw 450 new cases of lung cancer per year in their MDTs. And each surgeon attended, on average, 1.5 MDTs a week. So, if we use that as the gold standard, and we applied that across England, for 15,700 cases, we would need 107 thoracic surgeons. And if we looked at the MDT attendance, if we kept the same number of MDTs, we would need 113 surgeons. Now, looking back to that workforce data, if we assume that 63 of those mixed practice surgeons devoted half of their time to lung cancer surgery, which we're not sure that's true, we have a current total of 89 whole-time equivalents. So you can see we are understaffed in terms of specialist thoracic surgical expertise. So the bottom line, if we want to maximise lung cancer resection rates,